Ladies and gentlemen, welcome once again to another episode of the Think Clinical Podcast. My name is Hamza. It's always great to be here. Thank you so much for joining us once again. Today we are going to be looking at what is how you build sustainable healthcare models, and these are models that go beyond fee-for-service, as we commonly know and have here, where we charge. We see a patient and we charge a fee, and then when we look at this model is slowly dying, and it's not because healthcare isn't needed. It's just because we have a different dynamic right now in the healthcare business, and the economics of this just doesn't work anymore. So you need to be very comfortable looking at this in a different light, and that's why we are here today. My name is Hamza once again. Thank you for joining us. I'm hoping you enjoyed this episode like you do for all other episodes, and we will just dive right into it. So one of the things that we need to be aware of is that there has been a trap around fee-for-service, and just to paint a picture, you are a general practitioner, let's say somewhere in Nairobi or Lagos or Accra or in Johannesburg, and you charge, let's say, $100 per consultation, maybe $50. Let me be reasonable. That actually seems reasonable, but you see 30 patients a day, right? So if you are seeing 30 patients a day, that's not too much money. Now you are looking at rent, you are looking at staff salaries, you are looking at medical supplies, you are looking at insurance, you are looking at utilities. Suddenly that money you just made from that patient that you saw is no longer an actual profit. But you're exhausted because you are relying on volume to be able to see these things. So how do you move away from that? Because this is what we call the fee-for-service treadmill. You see more patients, you're more exhausted, but you have marginal profit growth, and just keep going back, and you are seeing more patients, and you are getting more and more exhausted, and your profit is not translating the way it should. The problem is not you as a practitioner or the skill set that you have. The problem you have is the model that you currently are using, and you need to be able to look into that more objectively. So let's look at this. Now let's look at why this is going to fail, especially in the African context, and I'm going to be talking about this purely on the African context because that's where I've had experience of practicing for so many years. Now Africa has the lowest per capita pharmaceutical spend globally. Now if you look at this, people spend under $25 a year on pharmaceuticals. So patients can't afford frequent visits. That's something you need to know. But chronic diseases are rising. Non-communicable diseases are projected to account for almost 50% of deaths by 2030 in Africa. So this is an opportunity here because then you can stay ahead of the curve and be able to provide the value and the care that people need. You need patients to come in regularly, and they also need affordable care. So there are two things. You have a need, patients have a need. So fee-for-service creates a friction there because it doesn't work properly if you are trying to get the most out of every patient visit. What is the first thing you need to be thinking about? You need to be looking at membership or subscription models, because in these cases, one, you can predict your income, but also you can charge lower because you can predict your income, you can project, and you can charge lower than you usually would, and so patients will be able to see you more frequently and still be able to stay within their budget. So the question here is that would you rather have 100 patients paying you, let's say, $50 each time they visit, or you have 100 patients paying you $30 monthly, whether they are sick or not? Which one would be preferable? The answer is as good as mine. The membership plan would actually transform your business. That's something that you need to really pay attention to, and you need to think about how that's going to work in your context. And if you have questions on that, you can leave a comment below or contact us, and we are happy to help you out and help you model this out. Now if you know exactly what is coming in, then you can plan, right? You can invest, you can breathe, you can actually not have sleepless nights thinking about what could happen the next day. Now you also have better patient outcomes. So when patients have already paid, they actually come for preventive care instead of waiting until crisis hits, right? So you are not spending so much of that membership plan money treating patients. You are spending it doing prevention, which is cheaper, and and you're able to keep your margins high. And you also have a lower acquisition cost because happy members refer others who add up to your membership pool, and you're able to get that running. So 70% of healthcare tech startups serve consumers directly or through B2B channels, with tech-powered health insurance and pharmacy aggregation models raising significant funding. So you have a clinic, let's say a clinic in Kenya, right? And you have 3 membership plans. You have a basic, you have a premium, and yes, you have a family plan, which covers up to 5 family members. If you put it in those tiers, then it actually puts you in a very good position to be able to offer the type of care that suits the financial need of everybody. Now, within 12 months, 40% of their patient base converted to memberships, because if you look at these membership plans, they become increasingly attractive to your patient base, and so people are very, very interested in coming to you. So this is the first thing that you need to do when you're moving away from the fee-for-service. Think about membership or subscription plans, especially for patients with chronic diseases, where you are able to offer them plans that suit their financial needs and also be in a position to offer them the best quality of care. Now, the second strategy that you can use to move away from this fee-for-service model is the B2B contracts. We have tried it. I tried it when I was practicing in Ghana, where we actually contract big companies directly instead of chasing individuals. And in that case, now you have a group of a company of 50 employees who are now immediately your clients just by through one contract and one transaction, in which case again it becomes predictable revenue, not as predictable as the subscription or membership model, but you know that you have a pool of 50 people out there in this company who would be coming to you if they have any medical issues because they have a contract with you. Now have 2 of those, 3 of those, 4 of those, have 10 of those in 5 years. Can you imagine the number of people? And if each of these companies has just 50 employees, that's 500 patients that you didn't have to go to individually, but you just have to see 10 companies to be able to get those 500 patients. This is the new way to think about your revenue flow and rolling away from that fee-for-service treadmill where you are putting in more effort, you're getting more exhausted, but your profit margins are so low. So when you look at employers, pitch them for an X amount of money per month, per employee per month. We provide annual health screenings, we do unlimited agent care visits and chronic disease management. Put it together as a package that is attractive to them. And you have to also look at what the insurance companies or what they will be paying if they were enrolling in any of the insurance companies, and try to match that. So if I come to you and I say, okay, pay me $200 per person per month or $100 per person per month, but it will give you annual screenings. Anytime this patient is sick and comes to hospital is free, and the chronic disease management, if they have any, is going to be included in that. That is going to attract more people to you than you can ever imagine. Think about schools. Parents worry constantly about children's health in schools. I have tried this model in Ghana where I have gone to schools, especially very well renowned schools, to sell this idea to them. On-site school health services. You can actually station a nurse there, which is going to be like a satellite location for you, and you can always leverage that. The third way is to look at NGOs, partnering with them and offering care. So these NGOs are going to pay you to offer care to communities, to offer care to schools, to offer care to a group of people. And in Morocco alone, patient support programs involving more than 4,000 patients were supported by NGOs. So this could be you. This could be you positioning yourself with these NGOs to get the funding to provide the care for these patients. Again, this is a B2B business model that you need to be looking at. And so when you look at these two, just turning your attention to the subscription model and turning your attention to these B2B contracts, you need to be honest about cost and pricing. There's limited access to health in low-income countries, which causes limited access to surgical facilities and delayed service delivery. But this creates opportunity if you understand the unit economics. So you have to know your numbers. You have to understand how much it costs you per patient visit, not just the medical supplies, but how much your staff, how much time your staff is investing into it, how much overhead is allocated to everything. You need to see your average revenue per visit, so you know the cost per visit, and then you look at revenue per visit and look at your break-even volume. And this is how you lay out your math and be able to now target what you need to do when you're building these models and everything that needs to come with it. Now, when you're building your model, here's a framework for you to start with a sustainable model. Start with your core strength. Are you exceptional at chronic disease management? Then build subscription packages, right? Do you have relationship with local businesses? Then you prioritize the B2B contracts. Is your community trust high? Then you go into community health membership cooperatives. So you have to look at where your strength is. That's the first thing. Then the second thing is that you need to layer revenue streams. Don't choose one model, build 3. So your core membership subscription base, which is predictable income. You still have your fee for service for non-members because they will need care of some sort. So that's your second model. And your third model would now be the B2B contracts. If you actually adapt these 3 strategies, and adapting them is not easy. You need someone who has done or know how to roll this out to be able to model them correctly for you. If you need that help, again, where we can help you model this out and get it out there. But you need to be able to get these 3 out. Get a fee for service out, get your subscription model out, and make sure your B2B contracts are also out there. You need to always, once you start doing this, measure, track, and know your numbers inside out. The question isn't whether to change your business model, but by 2050, Africa's population will double, and creating a fertile environment for health innovation as traditional models prove inadequate is going to be your main tool to be able to overcome this. So will you change intentionally, or will you be forced to change? But whichever way, there will be a change, and you need to be looking at this more proactively than waiting for it to be imposed on you. This has been another episode of the Think Clinical podcast. Please remember to subscribe, like, and share, and we will see you in our next episode.